It is my great privilege to introduce our speaker today, Dr. Jason Allen. Dr. Allen received his MD and PhD in neuroscience from Georgetown University School of Medicine. His thesis focused on the modulation of neural injury by metabotropic glutamate receptors using cell culture and animal model of trauma. He completed neurology and diagnostic radiology, as well as 2 years of neuroradiology fellowship at New York University. Dr. Allen is currently an associate professor of radiology and imaging sciences and neurology at Emory University, as well as associate professor of biomedical engineering at Georgia Institute of Technology. He is also director of neuroradiology division and medical director of the Center for Systems Imaging at Emory University. His lab currently focuses on defining the changes in structural and functional brain connectivity after concussion, particularly in patients with vestibular impairment, and developing diagnostic and prognostic imaging markers for this disorder. In addition, he is interested in developing and refining neurorehabilitation technique for post-concussion vestibular impairment, as well as understanding neuroplasticity related to successful therapy. Dr. Allen, thank you for being here. And without further ado, I will let you take it from here.
Great. Thank you so much, Armin. And I also want to thank you and thank Vince for inviting me to talk today. And I also want to have two apologies up front. One for those who are missing OHBM to hear my talk. I appreciate you coming to hear this and skipping that meeting. And I also want to somewhat apologize that it's going to be a more clinical talk than you is used to in this series. I hope you find it interesting, but I will go through some of the clinical aspects before we get kind of into the meat of the imaging, just so you have a basis for understanding of the problem and what is it we're trying to achieve. So today, again, we're going to be talking about central multisensory processing in post-concussion vestibular dysfunction, which is a mouthful, so I'm going to mostly abbreviate that as PCVD as we go along, but hopefully it'll be clear as we move along. There's a quick disclosure. There's a couple grants that supported the work that I'll be presenting today. A seed grant from our department here, as well as a grant from Georgia Tech CABI Center. So I wanted to thank them for that generous support, and the RSNA. Also, I have a grant from them for this work. I do some consulting for University of California, but I won't be talking about anything related to that. So before I want to start off with this slide so that in case we run long and I don't get a chance to thank everyone who's worked on this project, I'd just like to start by thanking them, and particularly Rusty Gore, who is a vestibular neurologist at the Shepherd Center. Rusty and I have been working together for the past several years on this project, and he's instrumental in a lot of the data and hypotheses that you'll see behind the research I'm going to show. I also wanted to thank Jeremy Smith. He's a research scientist here at Emory who's done a lot of the fMRI and DTI work that I'm going to show you today. Ben Risk is a biostatistician here. Vish Aluwalia at Georgia Tech at CABI Center has been instrumental in helping me with the fMRI and some DTI analyses. And then finally, just Anna Trofimova, who was a resident and current fellow and soon to be a faculty member here at Emory and has been in my lab for several years working on this project. So just a thanks to them up front. So to begin with, we need to define what actually is the primary vestibular cortex, what it is we're looking at. And so in monkeys, it's well defined on an experimental basis. And it's actually this region here, which is the parieto-insular vestibular cortex. And I'll refer to this in the rest of the talk as PIVC, just to make it easy for me. But you can see there are a lot of other areas that are involved with primary vestibular processing, and particularly this area I'm going to show here is 7B. But several areas in the frontal lobes, as well as the adjacent parietal lobe and some of the occipital lobe as well. So in human, if we look for the analog for the PIVC, it would be located here, posteriorly in the sylvian fissure in the insular cortex and the overlying operculum. And how do we know this? There was a great study, meta-analysis several years ago now by Eulenberg and his group, where he looked at all the fMRI data using stimulation of the vestibular system. And for those who aren't familiar with how this is done, it can be done by caloric stimulation, in which you instill either hot or cold water into the external ear. And what that does is cause a current to flow in the semicircular canal and activate the vestibular system. Or you can apply a direct current just posterior to the ear here and through the skin, so galvanic vestibular stimulation, and that will directly stimulate the vestibular nerve as well. This can also be done with sound, and some people have looked at that as well, but I'm going to focus kind of on these two just for this slide. So what they found with the meta-analysis was, using caloric stimulation, there was activation and multiple studies in that region of that parieto-insular vestibular cortex of the monkey, the analog of the human. You can see here bilaterally. And when they stimulate, this is from bilateral stimulation as well. And if they stimulated galvanic stimulation directly, you can see there are areas that show activation that somewhat overlap, but are somewhat different from the caloric stimulation. And if you take a amalgam of those two, or union of those two, what you find is mostly centered around this region OP2 is the primary vestibular cortex, so the analog for this PIVC. I'm going to end up calling it PIVC through the talk only because there's been some other studies that I won't really touch on too much, but showing that a couple other areas right in this region also probably are involved in being the primary center. And then Kirsch et al. A couple of years ago demonstrated that this area of activation shows laterality. So similar to language function, which gets in right-handed individuals gets localized generally to the left hemisphere, and what we clinically usually think of as the dominant hemisphere, the left hemisphere. But in vestibular function, it actually gets localized to the contralateral hemisphere from the language side. So it goes, if you're right-handed, this is what you show here, right-handed individuals show primarily activation in the right PIVC. So to the what we would consider the non-dominant hemisphere, but dominant for vestibular function. And conversely, left-handed individuals show localization of activity mainly in the left side. So if you're looking at some of our results as we go along through the talk and see that laterality, it fits in well with this work of Kirsch et al. And just up front, all of the subjects in any of the studies I show you are all right-handed. So just again, the PIVC incorporates both the PIC and OP2, but for the purpose of this, I'm just going to call it PIVC to keep it easy. Brandt's group several years ago hypothesized the area called the Multisensory Orientation Center. And what the MSO is in the region of the PIVC, and in fact, it encompasses the PIVC. And that area involves the next step in processing. So PIVC, if you think of that as just a central primary area, this is the area where we bring in other inputs. And as you can see in this diagram from his paper, inputs from the thalamus come up, and this is going to be inputs from the vestibular nuclei themselves, as well as from somatosensory input. But you can also see there's input and output to the visual primary and secondary visual association centers, and including this area here, which I'm going to bring up several times in the talk, MTV5, which is the middle temporal V5 visual region, which is an area that's involved in understanding visual motion. And so you can see there's inputs and outputs that are all coming into this MSO. And in fact, I hope to convince you at the end of the talk, there's lots of other inputs and outputs into these regions as well. There's a second important region for my talk in particular is the visual vestibular region. So the visual vestibular multisensory conversion zone. And this is work done by Della Justina et al. And what they showed is in patients with in a task fMRI paradigm, they showed them a checkerboard stimulus, and they look for activation through the visual system. And as you expect, you see in the occipital lobes, but you're also seeing it anteriorly here in the frontal lobe. And this is the middle and inferior frontal gyri, as well as several other areas. Then they did galvanic stimulation, and they looked to see where the activation patterns were for that. And you can see several different areas are lighting up. Obviously, we're not getting really the occipital lobes this time, but we're getting several other areas, including in that region of the frontal lobe. But most interestingly, when they did simultaneous visual and vestibular activation or stimulus, what they saw was activation primarily here in this inferior and middle frontal gyri, and of course some in the occipital lobe as well. And it's this area here, though, the MFG and the IFG, that they've named the Visual Vestibular Multisensory Conversion Zone, or VVMCZ, because that's a mouthful. So to review briefly kind of the overall architecture of the kind of primary areas of the vestibular networks or processing areas, you have the PIVC surrounded kind of by the MSO, incorporating it and including areas around it, and also the VVMCZ. And these are the three kind of primary areas I'll focus on, but I also hope to convince you that there are a lot of other inputs and outputs that are important in this system. So another quick overview and maybe a little easier to understand format is, if we think about vestibular information and how it flows, it comes in through the labyrinthine bodies, which are shown here, so the vestibule and semicircular canals. And the vestibule basically tells you where your head is in space, and the semicircular canals tell you if your head is moving in space or not. So that information flows into the bilateral vestibular nuclei, and we quickly have bilateral information flow at that level, and then they decussate to the bilateral thalami. And from there, that information passes out to that PIVC and MSO. And again, we have some bilateral representation there. And finally, there's inputs and outputs into the system really from lots of different regions. So the VVMCZ, of course, more anteriorly than the slice I'm showing you. The frontal eye fields are sending information in and out of it. There's that MTV5 region. Visual association areas more posteriorly, which I couldn't include on this slide. And then the hippocampus, and particularly the posterior hippocampus, which is involved in spatial memory. So we have this very complex flow of information coming in and out that's being processed to tell you kind of a relatively simple function of where you are in space and whether you're moving or not. Very recently, Indovina et al. Published what they calling the structural connectome of the vestibular cortical network, and you can see they include in their title this multimodal, and that's again because a lot of inputs have to go into that vestibular region in order to make sense of the data. And when they looked at the modularity of the connectome using 794 subjects who were scanned using the HCP protocol, what they found was they could break it down into several different modules on each side. We'll just use the right side for example, but you can see in one module encompasses that PIVC region, including OP2 and PIC, the MSO kind of surrounding, oops, I'm sure I'll show you here. Here's the PIVC, that MSO region surrounding it, and the VVMCZ. And this kind of all forms one module as kind of a very primary part of the vestibular network. But already you can see there are a lot of other regions that are coming up here that throughout the brain that are structurally connected into these regions. Then what you did in that paper was to see the PIC region, which is part of the PIVC, so that primary vestibular cortex, and see what connections they had to the rest of the brain. And what I really want to point out is that you can see there are widespread connections throughout the brain. You have frontal connections, occipital connections, a lot of temporal connections, both medially and laterally. And so there's a rich input and output that is happening into the primary vestibular cortex, and that's going to become important a little bit later in the talk. Zuellenberg's group, again from Munich, they looked at trying to define kind of the functional human vestibular network in a very recent paper as well. And what they did was basically take several ROIs that were based upon their prior meta-analysis and their work, as well as from areas, the homologs from non-human primates into the humans. And so that's that area 7 you see here again that I mentioned before, kind of an MSO region. And they used several of these inputs and then tried to look at the functional and structural connectivity between those sites and several different network measures. I just want to kind of highlight really probably this one, which is the functional connectivity network. This is not lateralized. The one on this side is lateralized. And you can see that, again, there's a lot of interconnections between these regions, as you would expect. Here's OP2, or we're in the region of PIVC. Here's the region of MSO. And you also, again, have a lot of bilateral reciprocal connections between these regions on each side and between several different regions on each side to their homologs. Similarly, you get a slightly different, of course, but a similar structural connectome here, connectivity, connectogram is what I'm looking for, with DTI data. So they also show there's a functional connection between these as well as a structural connection. But you can see this outlined, quote, vestibular network is a little bit more restricted than what Innovina had shown, and doesn't include a lot of those other areas that are probably providing input and output from this network. So why am I interested in this? Well, I'm interested in this coming from the clinical side of vestibular disorders. And really briefly, we can separate vestibular disorders into peripheral or central. And if you look at peripheral vestibular disorders, so those are going to be ones that are, again, involving the vestibule and the semicircular canals, or the vestibular nerve leading out of there. These are the 6 most common peripheral vestibular disorders, some of which you probably heard of: BPPV, or benign paroxysmal positional vertigo. This is very common in elderly patients and involved in otolith getting knocked off and floating around in the vestibule. But there's several other ones, vestibular neuritis and things like that occur. And traumatic injuries, particularly those, or generally those more severe than concussion, can cause some of these peripheral disorders. So of course, it could dislodge an otolith and cause BPPV. You can actually get a direct concussion of the labyrinth body, and with hemorrhages and things like that in there. And you can also, if you have a fracture, you can develop a perilymphatic fistula as well, where fluid's draining out of here. These are a little bit easier to understand, and again, occur usually in traumas that are more severe than concussion, and are of less kind of interest to me in that we have a clear understanding of what's happening when you have a direct injury. There are a lot of central vestibular disorders as well, and of course, I'm going to go through these, but these are ones that arise from injuries or dysfunction of the cortex as opposed to the labyrinthine body itself. You can quickly look through all these, and what you'll see is a notable lack of some sort of post-concussion vestibular dysfunction, or again, PCVD, which is what I study. And it's, until recently hasn't really been appreciated how important vestibular dysfunction can be after concussion. So this is kind of the niche that we wanted to fill with our research, to understand the connections, the symptoms, and the treatment of this disorder. To back up really briefly, what about concussion, and why is it important? So there are up to 3.8 million concussions occur annually in the United States. 60,000 of those, at least, in high school sports population. This is probably a gross underestimation, because people don't like to report their concussions because they may be sidelined. This is a really old number now from 10 years ago, but at that time they estimated it cost $12 billion in direct and indirect costs, concussion, to the US every year. And importantly for me was that vestibular symptoms occur in up to 80% of patients who have concussions. So it's a very prominent symptom, or common symptom, that occurs. For those who are less clinically oriented, you're probably wondering what exactly I mean by vestibular symptoms. So this can range from anything from dizziness and vertigo, which you're probably familiar with. So dizziness is a sense of being dizzy. We've all experienced that. Vertigo is actually a feeling that the room itself, the spatial area you're in, is spinning around you, as opposed to you being dizzy. But spatial disorientation, imbalance, and particularly autonomic distress can be accompanied by symptoms. So people who are experiencing autonomic problems may actually be as a result of vestibular dysfunction and may be overlooked. Otherwise, it's also important to note that dizziness at the time of the concussion does predict a prolonged recovery. It's common in blunt and blast injuries. People who have prolonged symptoms, up to 80% of them report having dizziness and vertigo. And again, we just went over that post-traumatic injury could be either central or peripheral, but it's really the central that I think predominate. I'm showing the next slide or two, in 2 slides, but the peripheral injuries can be there as well. So how about other impact for that besides money, financial? So this is a nice study out of Philadelphia Children's several years ago now. They looked at kids from 5 to 18 years old who had concussions, 250 of them, and looked to see how long it took them to go back to school or be cleared for full activity. And you can see in the patients who did not have any vestibular symptoms, they returned to school quite quickly, within a week, and they were cleared for full activity within a month. However, patients who had vestibular symptoms, they didn't return to school on average up to 60 days, so 2 months of lost school. and they weren't cleared for full activity till nearly a third of a year. So clearly a significant difference between those with vestibular symptoms or not. And so understanding what is happening in this population could have a great clinical impact. This is a study that was done by my collaborator, Rusty, looking at concussed athletes and healthy controls. So about 26 concussed athletes and nearly 100 healthy controls. And he looked at several different measures of concussion and then vestibular dysfunction. So this is a nice, easy questionnaire about concussion, the post-concussion symptom scale. And of course, they're statistically different between the two groups because we have a concussion group. But more interestingly, he looked at several measures of more peripheral metrics of vestibular dysfunction, which are here, and we won't go through all these. And then two here that are questionnaires that really get at more central dysfunction. And you can see that there was no difference on the peripheral measures. Only the central measures of vestibular dysfunction were statistically significant. So again, this is more evidence that we're dealing with a central problem and not just a problem with the inner ear. This is a paper out of Temple a few years ago where they looked at patients with concussions and did a virtual reality balance assessment and of them to see. And what they found was that the dynamic visual motion was, using that was the best discriminator between those who had a concussion and those who didn't. And that was despite these patients not having an oculomotor dysfunction. And by what I mean by that, I mean, there's been some work to suggest that concussion can cause difficulties with eye tracking and eye movements. And these patients didn't have any of those, yet they still were having problems with visual motion. And interesting as well that they found that these differences may persist well after these patients were, quote, clinically returned to normal. So they were, the normal time in the past that's been suggested was about 2 weeks most people recover, and these patients still would show, you could discriminate between them even beyond that time period. So that leads us to the hypothesis that we generated for what might be happening in post-concussive vestibular dysfunction. And so a patient has a concussion. We hypothesize that there's probably some altered vestibular function, and whether that would be initially from a peripheral injury or a damage to the tracts, maybe in the brainstem leading up, but somehow there is vestibular information is no longer appropriately coming into the primary vestibular cortex. Because of that, patients adapt using visual input. And this is not just related to concussion. There are other disorders like peripheral neuropathies where patients no longer have somatosensory information coming in from their legs, say, for example, that help them with balance. And so they respond by overusing or appropriately using visual input. And so, for example, a patient who has peripheral neuropathy may be fine when their eyes are open, standing with no difficulty, but as soon as they close their eyes, they tend to fall over because they don't have that input anymore. So we're hypothesizing the same sort of thing is happening here, where patients are now using these visual cues to say, hey, where is my head in space? Am I moving? Am I not moving? Because they're not getting appropriate vestibular information in. That's all great in the acute time frame because that's helping them because they're having vestibular problems. But in the subacute to chronic time frame, we hypothesize that there's either restored or perhaps increased vestibular input back into the PIVC. So now we're getting some information coming in from that, whether it's correct or not, but information is starting to flow back in. But these patients have learned a habit to use the visual cues as their primary source of truth, say. And so they're still having this increased weighting of visual stimuli into the PIVC in the face of this vestibular input coming in, and sometimes they're going to be mismatched. We've all sat in a car, for example, parked car, and someone next to you suddenly goes in reverse to back out of a parking space, and you suddenly feel like you're moving forward. So, but your vestibular system in a healthy patient would say, hey, now I'm not moving. That's an optical illusion. But these patients may not be able to do that because they're not trusting their vestibular input is enough. So finally, what that leads to is that when they get in a situation that has a lot of visual dysfunction or visual stimuli, they have vestibular impairment. And this is what we see clinically. And that's all happening in the subacute to chronic time frame. So these are the patients that we're interested in how we can help them and what exactly is going on to see if we can kind of look at this hypothesis. So I just kind of went through all this, but what I wanted to highlight to make it a little bit more clear, because kind of picture is worth 1,000 words, is that imagine yourself as a hopefully you're all healthy, person riding a bike fairly quickly down this pathway through the woods. And you can see there's a lot of visual information here that's distracting and complex. There's leaves, there's trees going by you. There's a kind of complex pattern here on the floor of the trail. And for a healthy person, they will kind of ignore this information and say, okay, I got that, it's moving. I know where my head is in space. I don't feel symptomatic because my vestibular system is otherwise working fine. But a patient with post-concussive vestibular dysfunction, when they do this, this is what happens to them. All that busy visual information comes in and kind of overrides or is overweighted and causes them to be acutely symptomatic. And again, with those symptoms that we mentioned earlier. So what we found, or certainly Rusty has found, is that as their patients are shown these more complex visual environments or in these environments, so you're riding a train or driving a car down a open field, not so bad. You're riding a subway car with pillars and things flying by your head, that's pretty inducing. And even some people who have normal vestibular dysfunction find this difficult to deal with. So as the scene gets more complex and moves faster, we're getting more of this visual vestibular input stimulation coming in, and they're becoming more symptomatic. And for a real world example, this causes these patients to have difficulty even going to things like a grocery store. Because as you can see, this aisle of a typical grocery store, again, has tons of visual information on either side that's complex, and especially they're pushing a cart and moving down here. Patients with PCVD will become acutely symptomatic in this setting where you or I or a healthy patient, a healthy subject would have no problem dealing with that extra information. A couple quick clinics, so that's the kind of setting the tone of what we're looking at. A couple quick clinical tests I want to mention so that you can understand our correlations we're going to make later with the data. The first one is the VOMS, or Vestibular Ocular Motor Screening Test. And this is a quick test where basically patients are tested on several eye movement, different eye movement paradigms. So horizontal and vertical pursuits, saccades, and looking at convergence. And convergence is just bringing an object from far to near and seeing how the eyes are accommodating to it. Then we have ones where the head is moving, but the eyes are staying in one place. So horizontal and vertical VOR. And then this one's most interesting to us, but this is the visual motion sensitivity test in which both the eyes and head are, the eyes are fixed and the head is moving along this target. And so this is one where you're going to have to ignore your visual information and listen to your vestibular information coming in, because your eyes are telling you something maybe a little different. You're stationary, where your body's telling you you're moving. And it's been shown that if you have, so the symptoms, let me go for that really quickly. So what we do is they have a baseline symptom and we rate headache, dizziness, nausea, and fogginess. And these are the symptoms that patients tend to complain of in PCVD. At baseline, then we, after each of these maneuvers, excuse me, and if you have an increase greater than or equal to 2 on any of these during one of these maneuvers, that has a 96% positive predictive value for concussion. So it's a pretty sensitive test. The other one I want to mention briefly is, so that's qualitative testing, because we're asking them how they're doing. Quantitative clinical testing that Rusty does up at the Shepherd Center. And really briefly, there's a sensory organization test, or SOT. And basically, patients stand on a plate and look at a screen, and they do different things. First, the plate stays still, and either they have their eyes open, closed, or the screen is moving, but the plate's staying the same. So they have to kind of integrate these two different functions. Or the plate is moving and the screen either stays the same while they're looking, or their eyes are closed, or both the plate and the screen are moving, and so they're swaying together. And so that's a way to get at try to quantitatively demonstrate vestibular dysfunction. There's also the visual motion sensitivity test you can do where the patient, so this is actually what that screen and plate kind of look like. Here's a person standing in it. We can do the OKN test where we have lines that move different directions moving across. And if you've ever experienced that kind of thing where you've ever looked at one of these spinning, and it can be disorienting, again, even to healthy people. But obviously it's worse for patients with vestibular dysfunction. You can see, of course, they're in a harness because they might fall over. And then we also have a kind of a virtual real world example where you can see you move down that kind of grocery store aisle, and we can control how much visual input is here. So easy would be a couple things on the shelves, and then difficult would be this would be loaded with visual information. And then we check to see how the patients move when they try to shift their balance to maintain their posture. I'm not going to go through this really at all, but this is just showing that there are differences that we detect. The ST is subacute, H is so this is subacute concussion patients with vestibular dysfunction. We test them between 2 weeks, generally 3 months, but up to 3 or 4 months after their injury that they're still having symptoms. And you can see we can just differentiate between these groups depending on different tasks. This is the grocery store task with different levels of difficulty. And we can also do the same for chronic patients. So here, this is healthy control, this is subacutes, this is chronics, and this is after therapy, the DC. And you can see that we see differences between these groups, and in some of these cases, we can see improvement after therapy. I briefly need to mention what the therapy is, because this is what drove the fMRI project I'm going to show you next. So the therapy consists of having patients watch these videos, these scenes that are going to either be neutral to them so they can watch without problem, or they're going to induce symptoms like that going down a grocery store aisle or on a subway, or for example, this one of some idiot riding his bike through Manhattan's street. And so you can imagine a patient who has dysfunction with trying to process that visual and vestibular cues. This is very provocative to them. Basically, then they watch these on a tablet over several weeks, and they get habituated over time. So they start on the easy ones, and they slowly try to move up to a scene that's going to be very provocative to them. And then they stop, and then they slowly move up each day until over a course of 6 weeks, they're no longer finding these disturbing. And just briefly, this is a paper we published showing that the therapy works. I won't go into what all these acronyms mean, but basically these are individual patients before and after therapy, and you can see that we saw statistically significant improvements in all these. So it's clearly an effective therapy. Okay, so this is the starting point for what we were interested in. There's a hypothesis up top, and here's a simplified schematic of what was known at the time, at least, of the vestibular quote network. But our question was, where was the issue? Was it peripheral input coming in, which we think is probably not, or an area with dysfunction of the PIVC? Did you actually injure that, or is it not working properly? Or any of these inputs or outputs to the system, or one of those actually be the issue, either over or under activated? So first we looked at structural connectivity in our patient population, and I'll back up by giving you an overview for trauma. So trauma has a long history of looking at diffusion tensor imaging and others, higher orders, and have found injury, as you'd expect, right? So some of these tracks show areas of injury, particularly long fiber tracks like the corpus callosum or the SLF. However, in concussion, it's a lot more confusing about these kind of more minor traumas. I mean, you have a big injury with a bleed or contusion, it's clearly why you disrupt a fiber tract. But in concussion, this is just a paper I published a few years ago, where I don't know, 5 years ago now, where we looked at just a number of papers that reported FA metrics and the timing of the concussion, and whether they were increased FA, decreased FA, or didn't show any change at all. And we plotted that against the timing from concussion. And what you can see is acutely, several of these publications had showed increased FA, actually. Kind of opposite what you might initially think, FA being a marker for, well, it's complicated, but maybe a marker for either axonal loss or axonal damage. And then in the chronic ones that are months to years, almost all of these are showing decreased FA is what we might think about. The ones in the middle are complicated, a lot of them showing no change and some showing either increase or decrease. And so we just hypothesized that there may be a continuum, and you have to pass through this area here, which I just call the pseudo-normalization period, that's similar to what we call in stroke, where you may not detect any of these changes even though they might be there. So when you're reading these studies, you have to always think about where you are on this timeline and whether you may not be detecting them because the instrument you're using, DTI, is not actually sensitive for that. But despite that, there's been several studies I'm going to show you here briefly. This is from Pratik's group out in California, and this is looking at concussed athletes versus ER patients with concussion but not athletes versus controls. But really, I'm just going to talk about these concussed athletes. And he showed that there were some changes in FA, particularly drawing your attention to those in the posterior fossa. This is the superior cerebellar peduncle and the middle cerebellar peduncle. And these areas may be the primary or decreasing the primary input up at the PIVC. If you disrupt some of the fibers, you no longer take away that primary cerebellar processing that's happening with vestibular input and no longer bringing it up top. So that it provides a possible explanation. But that they weren't looking at vestibular function, they were just looking at all comers. Excuse me. The UPIC group here several years ago did try to correlate changes in FA back with vestibular dysfunction. So these were, they looked at patients who had concussion and vestibular problems versus patients who just had concussion. And what they showed was those patients with vestibular problems primarily had decreased FA or selectively had decreased FA more so or different from the non-vestibular concussed patients. Again, in that cerebellum, also in the fusiform gyrus, which is an area that's involved in, again, visual motion. And so this, again, kind of provides a framework for why you might have this altered processing, vestibular processing coming into the system. Briefly on this paper from Wayne State is they looked at patients with blast injury. So this is not just related to blunt concussion, and showed in patients who have vestibular impairment that there were FA changes, throughout their brains, but they didn't actually correlate this with the degree of vestibular impairment. And blast injury is actually quite a different animal than blunt injury for those who aren't aware. There's also a nice paper here that looked at the sensory organization test, and here we have it. There's, again, I showed you the several different stages you can look at and a composite score, and clearly the patients with concussion did worse than the controls. And they looked at the connectivity using DTI across the brain and then selective regions, and showed that those correlated with the degree of impairment on the SOT. So suggesting that there was some structural changes that were driving some of the symptoms. Pratik's group again looked at some resting state functional data from the on concussed patients and correlated that back to this. It doesn't really matter, but the Rivermead post-concussion questionnaire score at 6 months. So kind of another marker of degree of impairment. And what they found was there were correlations with changes in connectivity of the visual, occipitocerebellar, dorsal visual stream, and posterior DFM that correlated with how well you were doing at 6 months on. And of interest to us is this dorsal visual stream pathways, because this is also what's probably coming into the PIVC and coordinating between the frontal lobes and the occipital lobes, and probably includes the MTV5 region as well. Just a couple quick more papers. This is a great paper looking at nearly 100 athletes with concussion, and they looked at resting state at several different time points, as you can see here. And the point I want to bring up here is what they found mainly was that the regional homogeneity of the middle and superior frontal gyri on resting state, and this is a marker of kind of local connectivity, acutely at 24 hours, correlated with whether they were going to have persistent symptoms. And this was persistent symptoms even after the patients had been cleared to return to play. So clinically, they were considered, quote, normal, but they were clearly still having symptoms. And why am I bringing that up is because if you remember back to that diagram I had in the beginning, the middle frontal gyri, the area that they saw was right in the region of the VBMCZ. So again, vestibular impairment driving persistent symptoms. And this was the only discriminator that they found on their resting state metrics. I'm going to gloss over this and just say that the posterior hippocampus is involved as well. This is an MRS study and showing that there's changes there that correlate back with the VOM scores, particularly the VMS. And so that's the kind of rationale for the posterior hippocampus, which is involved in spatial memory. So what did we do? We took those videos. I developed a task block-based fMRI design to use the videos that were being shown to the patients clinically, and we showed them to them in the scanner. And what we had was they watch a 30-second video that we either classified as a provocative or a neutral video, and that was, did it induce symptoms in the patients or not? And they were going to rate them, and they rated them in the scanner. Actually, after watching the video, They rated whether what symptom they were having at the time that was their worst, or no symptoms, and then the degree of increase in their degree of symptoms. So now I'm feeling a 2 out of 10. This is 8 out of 10. Excuse me. And then they watch across here, and they show them these multiple videos over time, and mixing in between provocative and neutral videos. This is just to show you, this is a measure of optic flow, that the provocative videos had significantly more mean optic flow variance, and maximum optic flow than the neutral videos, as kind of as expected. And then the control subjects really showed no symptoms on the neutral videos, and very minimal. This was actually one subject who had some minimal symptoms on the provocative videos. But you can see that patients who had post-concussive vestibular impairment showed even some symptoms being neutral but mild, but a marked increase when they watched the provocative videos. So this was inducing their symptoms while they were in the scanner watching them. This is just showing you that there's differences between the groups, as you'd expect. Again, these are VOMs is looking kind of more the central dysfunction, and we didn't see any changes in the peripheral. So again, suggesting these are central dysfunction in these patients. These are just the mean activation map for this paradigm. We're taking the provocative and subtracting out the neutral videos in controls. And as you'd expect, we see a lot of visual association areas lighted up and having a lot of activation, as well as in regions of the frontal eye fields. When you look at the post-concussion vestibular dysfunction patients at the subacute time point, we still see that visual association areas lighting up, but you can just appreciate here there's a lot of other areas that are involved that are getting increased activation comparing to the controls. They're doing, quote, more work trying to deal with these provocative videos. And this is when you actually compare the PCVD patients versus the controls when in that provocative minus neutral contrast. And these are the areas that are selectively activating. This is, again, right in the area of the PIVC and MSO, right? So on the right side, because they are right-handed. You see other areas, obviously, as well, too, in some of the contralateral side going up, but a lot of activation there. And importantly, we didn't see any evidence of hypoactivation or decreased activation between these groups. So it wasn't really a problem that an area might have been directly damaged. It was more a problem that areas were getting activated that probably, or to a degree that they shouldn't be. This is just the localization of those areas, and I want to point out that this here on the right side, this is the PIVC and MSO that they were activating, and this is the VBMCZ that was getting activation. So we have hyperactivation in that module of those areas that are occurring in these patients. So they're feeding more information, or they're trying to process more information in those areas. We took regions of interest for correlations throughout those areas that we either got from the work I showed you initially or from our own studies. And these include, again, MTV5, the posterior hippocampus, PIVC and MSO, the BVMCZ, and the frontal eye fields. And we correlated that back with those VOMs testing that I described earlier. And what we found was there were significant correlations in the degree of activation while doing that task of provocative minus neutral videos and their VOM score impairment outside the scanner, performed just before they got in the scanner. And so we have a lot of those areas are showing direct correlations, suggesting that these are actually responsible for their symptoms. I mean, it's not a causation, but it's certainly a correlation. We then looked at the resting state data using ICA analysis and saw that in the patients who had the concussion versus controls, we had an area of the in the right postcentral gyrus and the right middle frontal gyrus, again, this is the VBMCZ, that were more strongly correlated with the default mode network than in controls. And this is important only in that the DMN has been shown in patients with concussion, they may have a problem turning this DMN off. So the DMN should be only really activated when you're at rest, and when you're doing a task, it should turn off. And so it may be that they're having difficulty with this connection. They may be causing the DMN to stay on when they shouldn't, but I mean, that's all pure speculation. We also defined the vestibular somatosensory network here in everybody, and we saw this area in the right prefrontal cortex that was increased connectivity with that network in the injured patients versus the healthy controls. We also saw there were some changes in graph theory So we had increased global efficiency, cost, and degree in the right anterior insula and the right posterior hippocampus. So areas, again, that are involved in processing of vestibular information. And there was that increased average path length in the left posterior hippocampus as well as in the occipital lobe focus. Then we wanted to, more importantly, wanted to look at correlations, again, to see were any of these increased hyperconnections clinically meaningful. And what we saw going back to VOMS data, so here are the ROIs we were using, we saw that there was increased connectivity, or sorry, excuse me, the degree of connectivity was positively correlated with how the degree of impairment on VOMS, both at baseline and as a composite post-baseline score. And you can see, again, these are the areas BIVC and MSO being involved, the insula, middle frontal gyrus, so the VVMCZ, the posterior hippocampus. I'm going to kind of briefly go through these, but basically when we broke down each of the areas, whether it was correlated with eye movements, which are here, or with the head movement, or both together, we get kind of different correlations as expected. But most importantly, this is the correlation that kind of simulates visual motion sensitivity. And again, we can see that kind of cluster of the PIVC and MSO being together, as well as the VVMCZ, and this hyperconnectivity between these regions, or the degree of correlation, the degree of connectivity correlates directly with the degree of impairment. This is with the objective testing I mentioned earlier, the SOT. So we also see similar findings that how poorly the patients do on the SOT correlates with the degree of connectivity between and within these this vestibular cortical regions. And here's that grocery store one showing kind of the same thing. So to back up a little bit, this was the network that was proposed by Zuhlenberg's group. And you can see that there's a lot of areas that aren't included here that we found that are important and being activated in our task and have hyperconnectivity on the testing state analysis. And so what we were interested in was trying to define, well, really, what is the vestibular network? And so I showed you already that there were regions like the frontal eye fields and others that are involved in eye movements that are getting hyperactivated or have increased connectivity in there. So they're clearly being involved in multisensory processing. But there's been other data showing that affect or affective regions are involved. And by affect, I mean psychological, like anxiety and depression. So on this, these two left figures here by Passamonte et al. From a couple of years ago, what they did was have patients who, not concussion, but persistent postural perceptual dizziness, or 3PD. These patients are very similar in terms of visual stimuli provoking vestibular symptoms. They don't have to be related to concussion, though. There's other etiologies for them as well. But basically what they showed was in that inferior frontal gyrus region, that the degree of activation there was actually correlated with measures of neuroticism. And just briefly, neuroticism you can think of as how likely someone's going to be anxious or have negative affect. So they did see correlations there. So clearly regions of affect are involved. And this is just showing the same thing, but connections with occipital foci. And then this paper by Lee et al. In the same kind of group, 3PD patients, they saw on resting state fMRI that there was correlations between the degree of connectivity amongst multiple nodes and dizziness handicap index, a measure of cortical or central vestibular dysfunction. So that's not surprising. But they also found correlations with the Beck anxiety index and the Beck depression index. So these are measures of obviously anxiety and depression, and clearly the degree of connections between these regions correlated with their impairment on those scores. So I look like I'm running out of time, so I'm going to just kind of go through this a little bit more quickly. But so we wanted to try to get a fuller picture of what the vestibular network might look like. So what we did was we came up with several ROIs, the ones we that were in the literature previously, ones that came out of our testing group, and those that were either related to MVPAs performed in a group analysis, those relating back to our BAI or BDI, so anxiety or depression scores. And PCL5 is a measure of PTSD because we had some chronics, but we gave this to everybody And our healthy controls and subacutes, some of them do show some changes in PCL5 scores as well, kind of a measure of anxiety, kind of depression. So with those ROIs, we created, and this is with healthy controls and subacute PCVD patients, we made a structural connectivity map for everybody and made an adjacency matrix. And then we looked at the healthy controls and the subacutes separately and developed the functional adjacency matrices, put those together, and we got our core network for each of these two groups. Now, I'm not going to go into these details. You can kind of look here, or we can discuss later. But then what we wanted to know was, what was, quote, the consensus network? What were areas in both the healthy controls and subacutes that were conserved? And the thinking is that this network is probably something that's critical or maybe even essential just to do vestibular processing. So we have kind of, this is the baseline, what you need as a minimum, and then we can look at each individual to see what they have as how they might differ. So with that, we came up with these networks. So here's a consensus network, and the size of the spheres here relates to between the centrality of that node in this network. And so these are, the ones that are, quote, more critical for flow of information, or at least information has to pass through those more frequently to get around through the network. And conserved between both the healthy controls and subacutes, you can see the ACC anteriorly, several frontal lobe foci, and of course some in the occipital lobe and parietal lobes as well. This is and I know these are small and hard to see, but these are hard to show, right, of course, because they're complex. But here's the healthy controls, and you can see their pattern. Kind of, we have the core network there, but we also have some other connections that are unique to the healthy subjects. And here's the subacutes. And I think just looking at it, you can appreciate that we have had to switch a little bit away from some of these frontal connections to favor a lot of these occipital nodes. And so clearly a different pattern just by looking within that network from healthy and subacutes. And this is just showing the differences between them. So here's which connections were statistically significant, more either increased or decreased between healthy controls and subacutes, and vice versa. And you can see that there are a lot of new connections that are occurring that have increased connectivity in the subacute population versus the healthy control. So again, they're kind of changing not only changing a little bit of their inputs, but strengthening a lot of connections that are not really seen in the healthy controls. So we wanted to argue that this probably is a better, more fuller understanding of the vestibular, quote, network, because we have both these inputs and outputs that are related to eye movements, to affect, and all those interplay together, and particularly in cases of dysfunction. So when you're interested in looking at a patient who's having problems, these are the areas you're going to want to focus on, because these are the areas that are coming out as issues for them. We saw correlations with several of these networks and again, that sensory organization test. This is just everybody as a group, their performance, and here we're pulling out the subacutes, but you can clearly see there are areas of connectivity, like the right insula to the right inferior temporal gyrus and the left MSO to the right posterior hippocampus, that correlate, the degree of connectivity correlates with clinical testing. So in conclusion, I just want to point out that concussion related vestibular impairment is very common, it's very disabling, and it's probably overlooked by a lot of people. It's becoming clearer now that it's driving a lot of symptoms for these patients. Then that vestibular function really involves multisensory processing from lots of sites, visual, somatosensory, of course, the primary vestibular input, and the output, and maybe input too, comes from a lot of the other areas, including the areas that do eye movements and affect. And then really considering that fuller picture is going to be important when moving forward in analyzing patients with dysfunction. And then finally, the post-concussive vestibular dysfunction, it's an interesting disorder. And again, I think the data we've shown suggests that there is this increased weighting of multiple inputs into the central vestibular processing centers, and particularly eye movements and visual association regions, and that it may be some of the other data people have shown. Now, we didn't see any, I didn't mention this, but we didn't see any DTI changes in our patients, possibly because we're in that subacute time frame. But it may initially be you have the injury and dysfunction shown in the posterior fossa to supratutorial connections that drive the initial problem. then we suggest that, like other disorders, people will overuse their visual input into this to counteract those changes. That becomes maladaptive over time. And then we see these, not only on activation, we see hyperconnectivity at rest. And importantly, all of these areas correlate directly with clinical symptoms. So the worse symptoms, the more connectivity and the higher activation. And then we've already seen clinical improvement with this visual vestibular desensitization therapy. But as we start to pull out these patients, we might be able to target them much better and what exact kind of therapy that they need instead of using kind of a blanket approach to everybody. So I'm going to stop there. I know I went right to the time, and I apologize. I already acknowledged everybody, so I will go ahead and stop. And I have a few minutes, I think, to take some questions. Otherwise, I'm happy to participate in the chat function.
Thank you very much. It was a great talk. So if anyone has any question, please share on the chat screen in the chat box, or let me know to unmute you. So it's very interesting because in my previous work, I was seeing hyperconnectivity between occipital and frontal region in concussion in general, not specifically for these. So I'm wondering if that could be somehow related to this vestibular deficit or not.
Yeah, no, absolutely. And I think it's important to realize again that a large percentage of patients who have concussion have vestibular dysfunction. And so even though you weren't specifically looking for it, what you might be seeing is actually the vestibular side of these patients as opposed to the vestibular dysfunction of these patients as opposed to just a general marker of concussion. So it should also, again, be remembered, though, that those long tracks, those anterior to posterior tracks, are the ones that are going to be most sensitive to injury just from the biometrics of brain injury, right? Twisting and torsioning of the brain tends to get those long tracks first. So that's, they may be damaged and then they may be overactivated. So I think my guess is that you might be looking at vestibular dysfunction without actually knowing that you're doing that. Or you
and you were using that vestibular ocular motor screening to identify the individual, right? To categorize them.
I'm sorry, which tool?
So you were using that the vestibular ocular motor screening.
Yep. Yes.
Right? And is it during the acute stage, like in the right after the concussion, or in the subacute phase?
Yeah. So acutely, we were using in the subacute phase, but acutely you can certainly use the VOMs, and it will pick up as a good marker of concussion. For us, they needed to be positive on the VOMs to get in our study because that was it's a qualitative metric, but it was a clinical metric. And instead of just saying that they had symptoms, we had to demonstrate that they had those vestibular symptoms. But we were looking at the subacute and chronic phase, and so they're recruited, and then we repeat the VOMs that are used for correlations on the day of the scan. So just before they get in the scanner, we repeat the VOMs and several other questionnaires and use that for correlation. But they all, as you saw, show significant dysfunction on VOMs, but they were recruited because of that, so it's not surprising.
So I will stop asking my own question. There is some question I'm going to share with you.
Sure.
So the first question is from Christy. She's asking, what are some future problem of connectivity that you would like to solve?
Yeah. So what we're looking at now, so that's that consensus network, or that kind of final network I presented. We're now interested to see what parts of those correlate with which clinical tests. So which of those connections, hyperconnections or hyperactivation, correlate back with whether it's a eye function test, whether it's a balance test, and that will allow us to know how that's functioning in the system. And then again, with affective changes too, with measures of anxiety and depression. So that's one thing we want to look at. The other thing we're looking at is we're looking at dynamic functional connectivity now. And I have some preliminary data, which I didn't share this morning, but there are differences in the state dwell time of patients with post-vestibular dysfunction and controls. And it's been shown in other areas that concussed patients show a different pattern of how long they stay in a particular pattern and how many patterns they go to. And so we're looking right now at dynamic functional connectivity next to see if that's can shed some more light on what's happening. Are they having problems switching between these networks, and that's why they're staying with hyperactivation in a network? Or is it because they're, they don't have that problem, they just, the input's coming in is too high? So we're looking at that as well as one of the next step. And then another big thing for us is kind of getting, Armin, back to your question, is that we're enrolling patients who had acute vestibular symptoms but have recovered. And we want to see how they're different. So then we can actually say that these particular connections are the ones that are driving the subacute problem. Even though we've shown they correlate with symptoms, we'd like to show now that they correlate with not just a general concussion problem, but with persistent vestibular problems.
Thank you.
Yeah.
So Derek is asking, are you concerned about using both correlations to measure functional connectivity post-concussion, given that there is a hypothesized this metabolic environment, i.e. neurovascular coupling is disrupted?
Yes. So that's a really good point, and I think it's been shown, particularly in more severe trauma, but even in concussion, they've shown some changes in vascular reactivity and whatnot, and you may get decoupling. But we're also way out in the subacute phase, so we're no longer looking acutely. And at this point, most of them have already recovered. Again, these are patients who have structurally normal conventional MR imaging, so they don't have any microbleeds, they don't have any contusions, they don't have anything like that. And so at this point, we feel fairly confident that they're not having problems with reactivity. Yeah, that may be driving these, but that's a really great point. Acutely, that becomes much more important, and particularly as you get to more severe injuries.
So I can ask one more question. It's more general. I'm just very curious about why we were seeing insula in this type of impairment being hyperactive.
The insula?
Yes.
Yeah. So one, in the posterior insula, right? That's where that primary vestibular cortex lives. So that's not surprising that in patients who have dysfunction that they may have, increased or difficulties with processing information, so they may have to have increased activation in that region. But what we've also seen is, and others have shown, that the anterior insula is an output for a lot of somatosensory processing. So not just vestibular, but a lot of other processing occurs there and outputs to the insula. So we're not surprised to see the anterior insula involved as well, because once you do your processing in the posterior, the PIVC, the posterior insula, a lot of the information is probably handed off to the anterior insula that's disseminated out to the rest of the brain. So for me, it's not surprising to see those increased connectivity and changes in activation in those regions as well.
So we have another question.
Sure.
Shana is asking, you mentioned a study which compared ER patients with concussion and athlete with concussion. Is there a difference in the vestibular symptom between these two groups? And she followed up with a physically action group versus perhaps inactive group. What are the differences?
Second, I might need clarification on the second point, but on the first point, unfortunately, that study by Pratik, they didn't look at vestibular impairment, so we don't know if there was any difference between those two groups. We just know they had the athletes and the non-athletes. They were both concussed, but the non-athletes had concussion for a different reason. But unfortunately, for us, is that vestibular impairment being a driver has really only recently been coming out. So a lot of the older studies, it wasn't considered. And again, back to your previous study, Armin, was that some of the changes we've been seeing may have been actually vestibular problems and not other problems, but they weren't specifically addressed. In terms of the active and inactive, I'm not sure exactly what that means. Can I have some clarification on that?
So my guess is probably like between athletic, if someone has more exercise or not. And also the follow-up question was, what are the difference in these two groups in long-term recovery?
Yeah. So this was looking at I think you're talking about the one where we looked at 6 months Rivermead scores. If you're still talking about the ER one, let me just go back to it. I know I don't have, not sharing my screen, but I'm just going to flip back to this study so I can remind myself. No, this was actually all acute. So no, I take that back. That was just all acute. So I don't know, not sure what the long-term scores would be on those patients. Pratik hasn't published that data that I'm aware of. But for our patients, these patients are ones that already are persistent. So the reason that we can draw a lot of the or pull these out is because we have an enriched population. We're only recruiting patients who are already shown that they're having a problem. So they have symptoms longer than 2 weeks, and most of them have symptoms for more than 4 weeks. So these are an enriched population where we can really see these changes, because I didn't discuss this, but concussion is very heterogeneous, right? As you can imagine, hitting someone from the left side of the head is very different than hitting someone on the right side of the head, and what actually might get injured. And patients have a myriad of symptoms. And there's been a problem for concussion research in that, are these changes related to headache? Are these changes related to vestibular dysfunction? Are these changes related to eye movement or like eye tracking and things like that? So we wanted to use a very homogeneous, enriched population. And even saying that, I will say that our data, we do see that it's still a fairly heterogeneous group on an individual level. There is some variability in these connections. As a group, we can see them, but individually, it's still, I guess the kind of same thing with DTI. It's not quite ready for clinical primetime use, because on an individual patient, there's variability just between the subacutes, even though we're really enriching that population for exactly what we're looking for. So unfortunately for me, because it keeps me in business, but concussion is complex, and it's going to take some more work to figure out what's happening.
I have one more question if we have the time. You probably explained, I missed it. So I was trying to understand. So you use those video for a treatment, am I correct?
Yes.
Okay.
Yes.
So, and you were showing those video before the fMRI experiment, right?
No. Good point. So no, these patients, they have not entered therapy yet. So they get scanned prior to going into therapy. So this is the first time they've seen any of those videos. But that's an excellent point. So we don't have to worry about practice effects or already having seen these videos before. They are enrolled, they're seen clinically, and then they're enrolled, and then they start therapy.
Okay. And just out of curiosity, have you scanned them after the treatment?
So that's another, I didn't mention is things we're doing now, but that's another thing we're doing right now is what I'd like to see is, do they return to a quote normal connectivity pattern, or do they develop a new strategy to deal with it? And that may actually get a little bit at what the underlying problem is. Do they really disrupt something that we can't quite detect? Maybe we need more patients, or they each disrupt something differently, but they have a similar adaptation or pattern. So if they go back to normal, then we have to assume that all the networks are still intact and everything's working okay. They just have a learned behavior. So we're doing that right now to see what happens after therapy, and correlating that back with their degree of improvement on therapy.
Thank you.